All right, guys, good evening. I'm Dr. Sandeep, your surgery guy. I hope everybody is fine, everybody is doing well. Let's get focused and get started. So, I hope the audio video is clear. Right, guys, let's do it. Let's do it. Right. So, the objective for this session is try to give you 25 high yielding topics. I have split them into various aspects like questions and answers, a bit of T&D, and a bit of quick recap of the important topics. All right. Now, without wasting any further time, let's dive in. One of the most sorted out questions they'll ask you is about trauma. In trauma, they'll be asking about flows, cannulas, flow rates, everything we have discussed it. Usually when you look at the question, like would say, what is the flow rate of the cannula which is given in the image given is of pink cannula, and we all know from our rainbow diagram which we've already discussed in our rapid revision that you know what will be pink cannula will be 60 ml per minute, right? Now, two questions. What is the preferred size of cannula for trauma resuscitation? Remember, it is the 14 which is the maximum. Minimum is 16. The minimum is going to be 18. 16 is the other one that you can use. So you can use 14, 16 and 18. Look at the question. If they ask you which is preferred in trauma, if they ask you which is preferred in trauma, remember the preference is for 16 gauge. What is the minimum size of needle that should be used is 18 gauge. Now, another question that they can ask you is about the flow rate. When will you have maximum flow rate? When you have minimum resistance. When will you have minimum resistance? When the bore is wide, length is short. You have a cannula which is going to be wide bore, short length. That means the time taken for the blood to travel or the fluid to travel is less, and a larger bore will have low resistance, right? It will have low resistance. So this is one of the important topics. Another one is drains. We have discussed in great detail. This is your Jackson-Pratt drain. As I told you, drains can be divided into three categories. You have closed, you have semi-open and open. The closed drain works on the principle of negative pressure. The semi-open on capillary pressure. Open is on dependent drainage. What is Jackson-Pratt? Jackson-Pratt is a closed drain. It's a negative suction drain. So the options that were given, this is a semi-open drain. It is wrong. It's a Jackson-Pratt. It is used in abdominal surgeries. Works on negative pressure. Absolutely correct. So that is in terms of Jackson-Pratt drains. Okay. Now, the other drains, we have already discussed it. We have given you the rapid revision. I'm going to share this PDF with you. You will have all annotated notes here. So you have Foley's, which are, the standard Foley's, the three-way Foley's. You have the corrugated drains. You have the Romovac drain, the Penrose, the Jackson-Pratt, the Riles tube, the nasogastric tube. What is the normal length of the Riles tube? It is 100 centimeters. What is this new rule called as? How do you measure the length of the Riles tube required? It is called as nose, ears, and xiphisternum, called as the next rule, right? So remember, this is how you're going to measure the length of the Riles tube. What is this? Sangaskian Blackmore tube used in used in where? In bleeding esophageal varices which are uncontrolled on your medical as well as pharmacological therapy, right? Two balloons, gastric, esophageal. What is the volume of the gastric balloon? 300 ml. What is the pressure in esophageal balloon? That is going to be 40 millimeters of mercury, right? What is the other tube that can be used? A quick feedback. What is the other tube that can be used in your bleeding esophageal varices? One is Sangaskian Blakemore tube. The other one is what? Minnesota tube, right? Remember two tubes, Sangaskian Blakemore and Minnesota. What is this? Pigtail catheter. Where do we use? To drain any solid collections. That is your question number 2 to be remembered. Third question, energy sources. We have discussed it. Look at the image. In the image, you see a standard device which is used in surgery. Is very important for hemostasis. Works on a beautiful principle. It is only on the vibrating energy. It is nothing but harmonic scalpel. Now they ask you which of the following statement is wrong about this. It cuts the tissue while seals it. Absolutely correct. It vibrates at 20 to 50,000 frequency. That is its USP. It cuts and seals the protein via protein denaturation. Absolutely correct. It does not burn through. It generates friction. Friction generates heat. That heat denaturates the protein and then it cuts and seals. It takes lesser time. No. When you look at the monotherapy bipolar, the monopolar bipolar, you can just run, nothing will happen. You can just keep doing it without having any lag. Harmonic on the other hand, if this is the tissue, this is the harmonic scalpel, I'll put in the tissue and then I'll press it. I will lock, there will be a button here, I'll lock it, and then I have to wait till it sounds like ting, ting, ting. When it sounds like ting, 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 then it's done. So I have to hold and wait. It takes longer than your standard therapy, standard energy devices. You have the standard energy devices are monopolar, bipolar, harmonic, which are discussed. The only thing that they can ask you, is the difference between the cut and the coagulating current. I've told you before also, when you talk about the cut current, in the cut current, if I plot the graph between the voltage and the frequency, this is the voltage, this is the frequency, you will have low voltage but high frequency for cut current. The current has to run through to the tissue so that it can cut through. When we do the same in terms of the coagulating current, in terms of your coagulating current, you have voltage on one end, frequency on other end. What do you get? Yes, guys, you will have high voltage but low frequency. This is what coagulate. If you combine these two, the cut current and the coagulating current, if you combine these two, what do you get? This is what we call it as a combination of these two. A combination of these two is what we call it as the blend mode. Right? It is what we call it as the blend mode. Absolutely correct. Amazing, guys. Good feedback on the chat box. Keep it up. Let's go. Keep killing it. You have another energy sources which are going to be your new and your exam question. You have ligashore, the harmonica, and the thunderbeat. All these are combined energy sources. Do not get bogged up by the names. Anything else than monopolar, bipolar, harmonic, anything else is combined energy source. What is combined energy source? It's a combination of both electrical as well as the harmonic energy. That is nothing but vibrating energy. All right. Raghu, you're correct. The fulgurating current is nothing but the blend mode. It's almost the same. Don't worry about it. Now, another thing, we have spoken about the laparoscopic instruments. We all know this. Again, this could be your exam question. That is your the question number 4 or topic number 3. What do you have? Laparoscopic instruments. We have covered it. This is Hansen's sport. Varese needle has been repeatedly asked in your exam. What are they asking about Varese needle? Number 1, how do you confirm its position by saline irrigation, saline drop test? What is the angle between the needle and the skin? 90 degrees. What is the most common gas used? To create pneumoperitoneum. It is carbon dioxide. What is the flow rate for carbon dioxide? 1 to 4. What is the intra-abdominal pressure to be maintained? That is going to be 15. Less than 12 to 15 is what we keep it. We say less than 15. It is 12 to 15 millimeters of mercury. This is what is expected to keep. This is the lens that is used to attach into the camera. The standard lens is 30 degrees. This is SILS, single incision laparoscopic port surgery. This is your Maryland tooth dissector. This is the maximum they can ask you in terms of laparoscopy. That's it. Nothing more than that. Switch to the next topic. They can ask you about certain instruments. One of the major instruments that you will in the exam or in the surgeries, the abdominal surgeries, is abdominal self-retaining retractors. Remember, all 4 of them. The image that you're seeing is of Balfour, but you have the other ones. The Whitliner looks like this. You can have the clinches. The Gallopy has a single hook, whereas the Golligers have a flattened segment, right? So you can see Whitliners have like these claws. We call it as Gallopy has single claw, whereas the Golligers have a complete plate that is going to be put in abdominal surgeries. All these are abdominal self-retaining retractors, right? All these are abdominal self-retaining retractors, right? Now, another question, that is topic number 5. What is topic number 5? Wounds. Wounds are going to be absolutely important, especially your surgical wounds and the post-operative wounds. Now, according to the Southampton wound grading system, remember this word, Southampton wound grading system. They'll ask you many times, this wound can be classified as you can see, there's a massive hematoma. You can see all that red hematoma around it, which requires aspiration. The black one indicates necrosis. So according to Southampton wound classification, which grade does it belong to? It belongs to grade 5. What are those grades? Grade 0, normal healing. Grade 2, normal healing with some amount of erythema. Grade 3 is with erythema with other signs of inflammation. Grade 3 per se is clear or hemoserous discharge. 4 is pus. 5, there are 2 things. Either a severe wound infection or there's a hematoma requiring aspiration. Do not miss this, guy. This is your exam question. Even if there's no deep tissue infection, if there is a hematoma, massive hematoma requiring aspiration, that goes in the same category. Right? Now, along with that, you'll see another scoring system, that is your asepsis wound score. The mnemonic is asepsis. The only thing to remember in asepsis wound score, it is the stay in hospital for more than 14 days due to the wound is what is going to be important in asepsis wound score. All right, clear. Chalo. Again, with the wounds, it's about the dressings, it's about how you manage a chronic wound, and this is your exam question. The image that is given is what? It is your VAC. VAC stands for what? Vacuum assisted closure. But this word, vacuum assisted closure, is an obsolete word. It has been demolished. We don't use VAC any longer. Now the new word is negative pressure wound closure system, NPWCS, right? Now, what is the pressure in this? Minus 125. It is put in an intermittent basis. It decreases the interstitial fluid, decreases the exudates, it decreases the residual collection, and increases the capillary ingrowth. These are the advantages that you look. What are the other materials for dressing? Hydrocollagen dressing, which is also called as deodorm, actually used when you want to keep dressing for longer periods, that can be used. Another one is the severed sheet used in burn wound dressing. Remember, crepe bandage, that is your elastic compression, usually used for any venous ulcers, or you can use it as DVD prophylaxis, or you can use it as a management for varicose vein. This chamber is what we called as HBOC, same chamber, that is hyperbaric oxygen therapy chamber. Now it is questionable about its efficacy, but again an amazing tool for chronic wound which are not healing, right? Chalo. Now, this is with respect to the VAC system and the other ones which are important. Bed sores are a combination of same in terms of wound scoring systems. We have discussed it. What are the different grades you have? Grade 1, you can see non-blanching erythema, which is present. Grade 2, partial skin loss. Grade 3, you can see across, okay, grade 3, there is full thickness skin loss. Grade 4, you can see there is underlying structure involved, and grade 5, it is unstageable, it is covered in slough. You can see it is all covered in slough, right? That slough indicates a grade which is unstageable. Reason is I don't know the true depth of the ulcer, hence it is considered to be unstageable. Both asepsis wound score as well as the Southampton wound grading system is to evaluate surgical site infection. Both of them are for SSI, surgical site infection, right? Chalo. Another one, one more important topic is about nutrition. It's about the roots of nutrition. TPN is an important topic. The image that you're seeing, this is what we call it as the Hickman's line. Hickman's line is what? Central line. But central line which is not coming directly, right? You can have a direct access. If you talk about it in terms of central access, I can go like this, which is a direct access into the subclavian vein, or I can bury this under the skin. If this is the cannula, I'm burying this under the skin, and from there it goes into the subclavian vein, and this is what we call it as a tunnel central line. The other name for tunnel central line is going to be your exam question, is what called as the Hickman's line. Remember, Hickman's line is nothing but a tunnel central line. What is the advantage for these central lines? They are going to be very comfortable, because when you put a jugular access through here, subclavian veins are better when compared to jugular because they stick in an anti-dependent position. They're very discomforting. The patient can't move his neck. Every time he moves, the line moves. The line movement will cause increased chances of line dislodgement, line sepsis, wound sepsis. Everything is common or more prone in your jugular access. Subclavian vein is much more better. Now the question is, image shown is true except it is used for long-term parenteral nutrition, correct, known as tunnel central line, correct, reduces the risk of line dislodgement and line sepsis, correct. Can it? Chest x-ray is not required to confirm. Remember, I'm not doing chest x-ray to confirm. I'm doing it to document that I've put the line. That is the first important reason. The second important reason, yes, to look for position as well, right? When you talk about the central lines, remember, in emergency, if they ask you in emergency which is the most commonly put central line, it is your internal jugular vein. But if the question is what is the best central line, then it is your subclavian vein. Please do not goof up with this. Most common, best. Most common, which is going to be easily available, accessible, and I can get it right away, that is a jugular, because zup, you're gone into the jugular. Subclavian requires a little bit of skill. So for that to do, you require time. I don't have resources and time in emergency, so I'll not put subclavian. Otherwise, subclavian is considered to be best. All right. Now, in terms of parenteral nutrition, right? Now, when you talk about the total parenteral nutrition, remember, TPN can only be given or should only be given when there is no enteral access. As simple as that. Now, TPN can be given by two ways: peripheral, central access. What is the criteria? If the feeding requirement is less than 2 weeks, go with peripheral access. If the feeding requirement is more than 2 weeks, go with central access. Peripheral access are two types. You can see across here. One is going to be through the rest vein. Another one is PICC, peripherally induced central catheter, which remains for 7 days. Central access, subclavian, internal jugular, external jugular. Best subclavian, most common, is going to be internal jugular vein. We have already discussed about it, right? Now, these are the other forms of enteral nutrition through various mechanisms you have. You can have with the whole mouth, you're given the TPN, you're given the peripheral nutrition, the open ones. Remember, in open gastrostomy, two names to be remembered. The surgeries used in open gastrostomy, Stam and Witzel. Right? Stam and Witzel are what the difference is. Stam is a direct access, Witzel is a tunneled access. That's it. Witzel is tunneled access. Stam is a direct access, right? This is what you have to remember with respect to both the presentations, right? So this is in terms of nutrition. Very, very, very important topic. Max to max, no, they'll ask you in terms of nutrition, how much does the energy, does a carbohydrate release? The carbohydrate will be releasing 3.5 kilocalories per gram. We have 3.5 kilocalories per gram that is there in carbohydrates. Next is going to be fat, which is going to be at 9 kilocalories per gram. And the last one is going to be protein. And the protein is going to be at 4 kilocalories per gram. Guys, the class is relevant for any guy who is preparing for medicine, but this is more centrically placed in terms of your NEET exam, right? That is going to be an upcoming NEET exam. Yeah. So these are the important points that you have to remember across. Yeah. Now, another one with, let's move on to trauma. Very, very important questions. Forget about age, everything. The patient is having a road traffic accident. He is in an unconscious state. NCCT is unremarkable. Trauma, coma, NCCT normal. Single best answer is diffuse axonal injury. How do you know it's a diffuse axonal injury? You will see there is presence of punctate shaped hemorrhages between the white matter and the gray matter. Presence of punctate shaped hemorrhages between the gray and the white matter. You can see here, these are the punctate shaped hemorrhages which are present between the gray and the white matter. That indicates the patient has diffuse axonal injury, again associated with very, very poor prognosis, right? Now, what are the other things that you can see in the trauma? You can have extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage. Extradural hemorrhage is going to have a nice convex opacities or bilenticular opacities. This is subdural hemorrhage is what we call as the concavo-convex opacity, or also called as the crescent opacity. Also, they're called as the crescent opacity. Is that clear? Clear, guys? Okay. All right. So this is with respect to diffuse axonal injury. Now, another question in trauma is about your pneumothorax. Again, you will see patient has a trauma history. He has a contusion over the thoracic region. The heart rate is okay. The blood pressure is okay. Respiratory rate for now is fine. GCS is also fine. The emergency bedside ultrasound was performed. The image, what is the likely diagnosis? Now, when you do an ultrasound of the chest, you should know what is normal, what is abnormal. When you look at this particular image, this is a normal image. How am I saying it is normal? You can see this disturbance that is present that indicates the pleura is moving with respect to the lungs and the thoracic cavity. When the lung expands, you will see the parietal pleura and the visual pleura come closer and then they move apart. They close, they move. That this movement is what we call as seashore sign positive. That is seen in normal. But if you say there is no disturbance, it's like a normal presentation. That means the lungs are not able to expand or they're not able to move. That movement is lost, and this is called as loss of seashore sign. The loss of seashore sign is seen in pneumothorax. It is seen in pneumothorax, right? So this is a classical pneumothorax that you see. So you can see right side is normal, whereas the left side is damaged. So you have left-sided pneumothorax, that is also called as the stratosphere sign, right? Now, you can see a collapsed lung, the air cavity, I've shown you across it, that is in terms of pneumothorax. What is the standard definition of a flail chest? That is also an exam question. Now, when you talk about flail chest definition, the flail chest is when more than or equal to two continuous ribs are fractured at more than or equal to two different sites. That is in terms of your flail chest. I've given you the X-ray image for the flail chest as well. Now, majority of the times they'll ask you where would you put the needle in emergency, where would it be an ICD. For an adult, it is fifth intercostal. For a child, it is second intercostal space. And remember, the safety triangles margins, or I would say the boundaries are important. Remember, anteriorly it is formed by the pectoralis major, inferiorly by sixth rib, posteriorly by latissimus dorsi, and the apex is between the two muscles. That is your safety triangle. You put your ICD down there. All right. Now, when you look at the question number 11, diaphragmatic injuries, again very, very important. Remember, whenever there's a penetrating injury below the fifth rib, always rule out the diaphragmatic injury. This is your golden line to remember. Remember, how do you identify this? Presence of a gastric bubble and then a nasogastric tube in that gastric bubble indicates it is a diaphragmatic injury, right? So that's, you have to understand. Remember, the most common mode of injury for diaphragmatic injury is going to be penetrating, but the most worst is going to be blunt trauma to the abdomen causing diaphragmatic injury. It is associated with greater mortality. It is associated with greater mortality. Absolutely correct. Right, you can see the other forms of diaphragmatic conditions that you can see if you see a gastric bubble in a neonate, that is going to be Bosch-Talek hernia. If you see on the right side rather than on the left side is Morgagnian hernia. If you see that colon is herniating, that is on the right side is again a Morgagnian hernia. If you see a free gas under diaphragm, it is going to be, what is it? Hollow viscous perforation. These are the GI images that they can ask you. If you see there is an air bubble that is trapped between the diaphragm and the liver, this is what we call the Chilaiditi syndrome or the Chilaiditi sign, which is a false sign for free gas under diaphragm, right? There's a false sign for free gas under diaphragm, right? So all this are going to be absolutely important. We have discussed it. Another one is about renograms. Kidneys are very, very important. This is what we call it as MAG3, mercaptoacetyl triglycine. This is the gold standard. DTPA is the most commonly used or the investigation of choice to assess renal perfusion. Now you can see there are two kidneys. I can give you the right kidney and the left kidney. Right is the red line, left is the blue line. If you can see right across here, you will notice that the blue line, which is the left kidney, the dye goes in and then it excretes out of the kidney. This is normal. Whereas the right kidney, the red one, the dye goes in, but it is not able to excrete. It takes longer time and slowly it is excreting. So I would say the right kidney is obstructed, but it is not completely obstructed because it's still in the lower trend. If it was gone like this, that means it is retained, it is not excreting. So it is partially obstructed. So left normal, right partially obstructed. Again, a very, very, very important question, right? That's about the renograms. We have given you the normal renogram, the left obstructed. Both of them have a different trend. You need to understand in the same context, right? Renograms are important. Now, remember a very, very important question that can be asked from the GIT is about Hinchey's classification in diverticulitis. One of the greatest pickup point for diverticulitis in Hinchey's, where you have higher grade of Hinchey's, is vesico-colic fistulas. It is the vesico-colic fistulas that you need to remember. The other ones that you can see is a flower vase appearance that you can see. I hope everybody knows where do you see the flower vase appearance. That is going to be in the horseshoe kidney. You can see drooping lily sign where you have the collecting system duplication that you can see across here. Spider leg appearance you will see in polycystic kidney disease where you have thinning of pelvic calcium system. The adder head appearance, as you can see, the cobra head is like this, and this is the cobra head that is seen in uretrocele. Another important topic from the urology point of time is your schistosomiasis, which is a thimble bladder. Now, what are the two important things of schistosomiasis? Swimmer's itch and Katayama fever. You cannot afford to miss on it. Remember, the Katayama fever is associated with high-grade fever, with lymphadenopathy and visceromegaly. These are the important aspects that you need to pick across, right? Now, remember, what is the drug of choice is going to be praziquantel at 60 milligrams per kg. You will have Katayama fever. Swimmer's itch is the point of entry of the Cercarial larva into the body as well. Does it cause endocarcinoma? The answer is yes, but it is more prone for squamous cell carcinoma of the bladder when compared to adenocarcinoma. Now, a very important question in terms of the pancreas, that is going to be periampullary carcinoma. You will see double duct sign. I've given you the blue indication, the blue duct that I've drawn. It is the CBD, and the orange one is going to be a pancreatic duct. The double duct sign, inverted 3 sign, widening of C loop of duodenum, everything is going to be with respect to the pancreatic head cancer, also called as periampullary carcinoma. What is the most common feature of periampullary carcinoma overall? The answer is going to be jaundice. right? Now, if you see chronic pancreatitis, what is the appearance? Chain of lake appearance. Again, a very important question from the exam point of view. When you do, what is this image? This is your cholangiogram. You can see right across here what is happening. There's sudden cut of contrast indicating CBD obstruction. What do you see here? You can see two drainage of the pancreas, two divided ducts which are present. Where do you see two divided ducts in our pancreas? That is pancreatic divisum. That is your pancreatic divisum. All these three images are your exam questions. Can't afford to miss on. Now, if you see an image like this where you have an abnormal pancreas and the pancreas look like a bulky sausage, it is what we call a sausage of pancreas seen in autoimmune pancreatitis. Where do you see in autoimmune pancreatitis? It is a IgG4 associated antibody pancreatitis. What are the surgeries that you can do for chronic pancreatitis? Number one, beggar surgery, deodorant preserving pancreatic head resection. Frey surgery, what is that? Deodorant preserving pancreatic head coring with longitudinal pancreatojejunostomy. Another one is Puestos. Puestos is what? Longitudinal pancreatojejunostomy. Another one is your pancreatoduodenectomy. That is your Whipple surgery. When the head becomes quite bulky, you don't have any other option. What is the most common complication of Whipples? That's your exam question. The most common complication of Whipples is delayed gastric emptying, right? Vaccine and weaning of jaundice, very good. Vaccine and weaning of jaundice is also seen in periampullary cancer, usually associated with distal cholangiocarcinoma. Absolutely correct, Ashish. Very good. Right. Now, another one with respect to pancreatitis, if you have a patient of pancreatitis and you see one side of the lung is filled with fluid, it is called as pancreatopleural effusion, and that is because of pancreatopleural fistula. The only question that they can ask you is the only indication for octreotide, which is somatostatin analog in pancreatitis, if there is a pancreatopleural fistula. Very, very important. Do not miss on this, right? Now, another important component that you will see in the pancreas is about the cystic lesions, especially the pseudocyst of the pancreas. Remember, what is the indication for surgery in the pseudocyst of the pancreas? More than 6 weeks old, more than 6 centimeters in diameter, more than 6 millimeters in thickness. Out of these three, what is the most important criteria? The most important criteria for surgery in pseudocyst of pancreas, it should be more than 6 millimeters in thickness. The thickness is what it matters. What is the most common presentation for pseudocyst, or what is the sequelae for it? It is the chronic pancreatitis, which is more commonly associated when compared to acute pancreatitis. What are the other cystic lesions that you should be worried about? Three important cystic lesions of pancreas: pseudocyst, serous cystic adenoma, mucinous cystic adenoma. How do you know? Pseudocyst is well confined, large, thick walled, calcification in the wall, liquid and solid component. What do you have? Serous adenoma, multiple small lesions. There are internal septation, and then you have central stellate scar. Very important. Mucinous, it will have peripheral eggshell calcification. This is what that you have to pick up. That is your peripheral eggshell calcification, right? Now, remember a very, very important concept with respect to serous adenomas, that is a central stellate scar. Where do you see other sites? This is usually seen in a contrast CT, right? So what are the other conditions where you will see a central stellate scar on a CT? Focal nodular hyperplasia of liver, serous adenoma of pancreas, and renal oncocytoma. These are the three conditions where else you would see central stellate scar. Again, plastic surgery is an important question. It's been moving very fast. They'll ask you, usually now we're talking about the lip cancers, asked repeatedly, what is this surgery? You can see it has moved and then been the defect. There's a defect here. I have moved a flap and then I have pushed the flap and reconstructed it back. And this is what we call it as the Johansson step surgery. It is your Johansson step surgery. Guys, I'm so sorry. I know it's a live session, but I'm getting a constant call from the hospital. Just give me 1 second. I know it is important, but this is also equally important. Just give me a second. All right, guys. Sorry. Okay. Now, when you talk about the incisions, I told you about Johansson step surgery. Let's look at this. Now, remember, if there is a lesion in the lip and it is a malignant lesion occupying less than one third of the lip, we are a W-shaped excision. One third to two third, Johansson step surgery. If it is more than two third, total excision of limb, the total excision of the lip with hemimandibulectomy. Now you have various incisions that you have. The visor incision, which is going to extend from this, the angle of the mandible from one end to another end. It is usually used for carcinoma, tongue. It can be used for neck dissection. It can be used for the mandibular cancers. Another one is your modified Blair's incision. Very important. Where do you see modified Blair's incision? It is seen in your thyroid surgeries. Weber-Ferguson's incision, Weber-Ferguson lip split, Weber-Ferguson's incision. You can see starting from here, going here, and then it goes under the eye and then it extends. Used for maxillectomy. Kocher's incision. Where do you see Kocher's incision? The Kocher's incision is seen in thyroid surgeries, right? You cannot afford to miss on that. Right? Okay. Another incision that you have is the Kocher's incision, the rooftop incision, the hockey stick incision. If you have the same extension, this is also called as the chevron incision. This is also called as your chevron incision, right? So all these are important incisions from the exam point of view. Do not try to miss across. Now, nowadays, you get a lot of clinical questions which are relative to general surgery, and they've been asking a lot in terms of general per se. And one of the best examples are intraoral swellings. There are two swellings. You can see one swelling which is under the tongue, another one is extending. What is it? Is it a ranula or a plunging ranula? Remember, the ranula is only limited to the base of the tongue. It is also called as frog's belly. It is what? It is reason resulting from extravasating cyst. Remember, ranula is extravasating. Plunging ranula is a retention cyst. That is your exam question to remember, right? How do you know it's a plunging ranula? The other features, you have a thick yellow fluid, there is presence of cross fluctuation, the origin is in the sublingual glands, and it is going to perforate the muscle. Which muscle? The mylohyoid muscle. What approach will you take? Remember, even though it is extending into the neck, I'll not take a cervical incision. It will be an intraoral approach. That is what you have to remember across, right? Now, again, with respect to thyroid, all these images that are there is going to be an exam question. Everything I've summarized in one single go. You see there's a patient with a lateral neck swelling. I can see in the histopathology a samoma bodies. You can see empty cells without nucleus. There's orphan ani and nuclei. Presence of microcalcification on ultrasound. Everything points towards only one malignant lesion of thyroid. That is your papillary cancer thyroid. Then you're saying, sir, there's a lateral neck swelling. How are you saying papillary? Papillary cancer thyroid can also present to you as lateral aberrant thyroid. What is lateral aberrant thyroid? It is a malignant, that is nothing but metastasis from your primary lesion to the cervical lymph nodes without any evidence of primary lesion per se. That is what we call it as the papillary cancer thyroid, right? Now, another very, very important topic. This you cannot leave and go to the exam. That is going to be your vascular disease, and especially in terms of your varicose veins and the classification, that your SEEP classification. We have discussed it again and again. Now, everything about SEEP is important, but the most important point about the SEEP is about pigmentation, right? When you have a pigmentation, the pigmentation is going to be seen in a condition which is associated with varicose vein, and the pigmentation is because of hemosiderosis, not hemosiderin, because hemosiderosis, which is a 4A, you see the hemosiderosis is a combination of hemosiderin with melanin of the skin. This is what you're supposed to remember. Do not forget. Lipodermatosclerosis, which is a 4B. It is also going to present you as inverted champagne bottle appearance and the woody limb. Do not again miss on this, right? Corona phlebitic is your malular flare, right? SEEP classification in varicose vein is going to be absolutely important. Do not miss this before going to the exam. Identify the surgery in the lower limbs. Again, lymphedemas, very important topic. What is this surgery? You can see I have removed the entire edematous limb and then I have reconstructed back, and this is what we call it as the Charles surgery, right? Now, remember, the surgery in lymphedema is associated with poor outcome. It increases the morbidity as well as the cosmetic appearance is really, really poor. What are the limb reducing surgeries? You have the Homan surgery, the Thompson's, and the Charles surgery, right? Just look at the image and remember, Homan's is only debulking from one end. Thompson is to remove the subcutaneous fat and reconstruct it back. Charles is to remove the entire limb, excise it, and reconstruct it back. That is your Charles surgery. All right. So this is for lymphedema. Now, how can you have a question in a GIT or in a surgery without having an intestinal obstruction? But this time, the intestinal obstruction is more important in terms of gallstone ileus, that is regular striate, dynamic small bowel obstruction, pneumobilia, ectopic gallstones. All these put together is what we call it as the regular striate, right? So the regular striate is what it is going to be responsible for gallstone ileus, right? So regular striate, gallstone ileus, how would you manage is your exam question. Remember, I will not go ahead with cholecystectomy. I will only go ahead with relieving intestinal obstruction. As simple as that. So they have given you what is the most likely site of obstruction? It is going to be at the ileocecal junction, right? Terminal ileum is a better answer. So terminal ileum would be a better answer. Yeah. So again, inguinal hernia, very, very important. You cannot go to the exam without looking at the image of the inguinal hernia, especially the laparoscopic inguinal hernia. Especially the laparoscopic inguinal hernias, right? Now, in this context, you can see in the laparoscopic inguinal hernia, what are the things that you have to remember? This is what you see. This is your deep inguinal ring. This is your deep inguinal ring. You see these veins, these are your inferior epigastric vein. You see on the medial side, you have the vas deferens. In the lateral side, you have the gonadal vessel. How am I saying it is medial or lateral? Look at this part. This is the bone and this is your pubic bone. That is you have to remember. So pubic will be on the medial side, vas deferens, gonadal vessels. There's a peritoneal reflection and this is what we call it as the triangle of doom. Right? Remember, the most common nerve injured in a laparoscopic inguinal hernia repair is your lateral cutaneous nerve of thigh. Repeat the question. What is the most common nerve injured in open inguinal hernia surgery? It is your ilioinguinal nerve. What is the most common nerve trapped in the mesh? That is your iliohypogastric nerve. 3 nerves. Most common in laparoscopic inguinal hernia repair, lateral cutaneous nerve. Most common in open repairs, that is going to be ilioinguinal nerve. Most common nerve trapped when you put a mesh, that is going to be iliohypogastric nerve. Do not miss on that. Clear? So this is with respect to the hernias. 2 more things in hernias. Remember, the hernia classification is important, especially the European classification and the NEHAS classification. Okay. Chalo. Sutures and knotting, again a very, very important topic. When you look at the sutures and knotting topic, remember to identify and differentiate between the granny's knot and the square knot. As simple as that, right? So how do you know it's a granny's or a square knot? You see these threads. If both the threads are passing in the same direction, that is under the loop or over the loop, that is going to be reef or square knot. If one thread is going above and one thread is going below the loop, if one thread is going above and one thread is going below the loop, this is what we call it as the granny's knot. As simple as that, right? Chalo. Again, in transplant, very important. This is a kidney transplant image. You can see that flap image that is there. This across here. We're talking about this part. Talking about this is nothing but your Carroll's patch. Now, presence of Carroll's patch indicate that it is a kidney from a dead donor. As simple as that, right? Nothing more is important. Remember the criteria for transplantation. ABA grouping, Rh antigen is not important, but remember the blood group should match. In HLA, the most common HLA which has to be matched is HLA-DR, then HLA-B, and then HLA-A. That is in the sequence that you have to remember across, right? Now, what is the surgery that is illustrated here? It is your Heineken Muclid spileroplasty that is done for stricture, especially for when you're talking about in terms of gastric outlet obstruction secondary to a duodenal ulcer which is healed and resulted in stricture. Finney spileroplasty is also for the same reason. Ramsted spileromyotomy is for CHPS, congenital hyperpyloric stenosis. Jablois is also, see, Jablois for testis is different. That is hydrocele. Sac eversion that we're talking about. Jablois procedure here is also a procedure's name for relieving the obstruction due to stricture. It is a drainage procedure, right? King's College criteria for liver transplantation in emergency has been asked only once in your exam. So I would not be very keen on learning the whole protocol. But remember, King's College criteria differentiate between emergency and elective, usually associated with paracetamol toxicity. So you have emergency liver transplant due to paracetamol toxicity and non-paracetamol toxicity is what your King's College criteria tells you. If you know this much, that is more than enough. No need to worry about it. Right. The other surgeries that is usually asked associated with your peptic ulcer disease, is your gastrojejunostomy, Heineken mucous pyloroplasty, Jablois gastroplasty, and the finies, which I've already discussed in the images that you have given across here, right? This is a spotter. You just need to pick it up. That is a coffee bean sign on volvulus. What is the most common site? It is sigmoid colon. You can also have a cecal volvulus. Remember, the sigmoid volvulus is anti-clockwise. Cecal volvulus is clockwise in direction. Remember, very, very important topic. Now, the other things that you can see, if you see a target sign on an ultrasound, that indicates donor or target sign is intussusception. If you have a thumbprint sign, it is ischemic colitis. If you have a whirlpool sign, it is mid-gut volvulus, right? Beta, it is not recorded. I'm right here. I'm right in front of you. You can bombard your questions. You need to utilize this time. We are trying to summarize everything in a quick rapid revision. See, right now, it is not time to learn. It is time to revise. That is what I've been emphasizing. Listen to the topics that I'm emphasizing on. Just go back, revise, and re-revise again. That is what the motto should be, right? Now, before I summarize, the last question that I would like to discuss is about the stones. They've been asking many times, especially in terms of the electrocrystalline images. The electrocrystalline image that you have is the envelope crystal, the dumbbell-shaped crystal, the coffin lid, you have the rosette-shaped and the hexagonal. All these images have been asked in your exam previously, and their reasons have been sorted right across here, right? The whirlpool sign is not seen in intussusception. The whirlpool sign is seen in small bowel volvulus, right? Whirlpool is not seen in large bowel, it is seen in small bowel volvulus because of its mesenteric role that occurs. Volvulus is twisting. Intussusception is going, one loop of intestine goes into another loop. That is as simple as an intussusception, right? Clear, guys? So these are the important topics that are going to be asked in the exam. Few more topics that can be asked is in a laparoscopic image, especially what is this? This is called as critical view of safety. You need to have two ducts, which are, or two tubular structures. One is cystic duct, another cystic artery. Between that, you should be able to see liver parenchyma. And this is what we call it as the critical view of safety used for laparoscopic cholecystectomies, right? This is another exam question that they can ask you. What is the test? It is a starch iodide test. Starch iodide test is done for Fraze syndrome. So Fraze syndrome is also a very, very important exam question. You cannot afford to miss on it, and do not goof on the same, right? Now, in the same topic, in terms of images that I talk to you, it's the Zenker's diverticulum. How am I saying? It is on the left side. If it is on the, see, if Zenker's diverticulum, it will be present on the left side on the cervical esophagus. If it is on the mid esophagus on the right side, it is going to be mid esophageal diverticulum, also called as the bronchial diverticulum. Then you have epiphrenic. Epiphrenic is also on the right side. Remember, mid esophageal is a true diverticulum. Zenker's and epiphrenic is a false diverticulum, right? Now, you can see the other images that I've given you of the Zenker's as well as epiphrenic. See, how do you know it is Zenker's? You will see the neck region. It is a cervical esophagus. That's a very, very important pickup point. It is a cervical esophageal diverticulum. It is a cervical esophageal diverticulum, right? So this is what you have to remember in terms of important exam questions, right? Now, before we move down, I would like to take up a very important topic, that is trauma. But I'll give you, see, when you look at this, this one single slide consists everything that you need to know on trauma, right? I'll just make it very simple. When you look at the trauma, now trauma can be divided into the following components that I've been discussing across here. Number one, it is the triage. We all know the criteria for triage. We know the color coding for triage. That is important to remember. Now, after the triage you have done, you have to look for damage control. Damage control is to basically prevent lethal triad. What are the components? You have the criteria for damage control and the early total care. We also have the stages for damage control surgery, which we have discussed in detail. Do not forget to look on this, a very, very important slide. Now, once you have done this, look for the head injuries, which are going to be more morbid. Now, in this, you have to look for the NICE guidelines, the GCS scoring, the Nexus criteria, and the secondary brain injury. How do you know the secondary brain injury? Raised ICT. What do you have in raised ICT? Cushing triad. What do you have in Cushing triad? Hypertension, decreased heart rate, irregular respiratory rate. All these are going to be with Cushing's triad. Now, in the NICE guidelines, remember, requirement of CT within 1 hour, requirement of CT within 8 hours. Two important criteria. GCS, everybody knows how to calculate it. I'm not going to talk about much in detail, but you know what GCS is. The most sensitive criteria in GCS is your motor response. What is the maximum GCS? 15 by 15. What is the minimum GCS? 3 by 15. Normal 15 by 15. Intubated 10T. Why? Because there is no verbal response. I cannot take it 0. I have to take it T. Risk for coma if it is less than 8. And prophylactic intubation is also indicated when it is less than 8. All these are important points to remember. All right, guys. So this is about the head injury. Nexus criteria is to rule out is there any cervical spine injury or not. Now, no posterior midline cervical tenderness is the only thing to remember. Rest everything is adjuvant. No evidence of intoxication, normal level of alertness, no focal neurological deficit, and no painful distracting injuries. All these are your nexus criteria. After head injury, it is your abdominal injury. You have to do fast, especially for blunt trauma abdomen. Look for solid organ injury. Look for splenic injury. If there's splenic injury, you have to grade it and then operate it. Most important is the vaccination protocol. The vaccination protocol for emergency splenectomy. Now, in an emergency splenectomy, see, in an elective, I will do 2 weeks prior to the surgery, I'll give vaccine. Emergency, what is given immediate post-op? That is pneumococcal. Adult, it is going to be PPV23. Child, it is going to be P7. That is what is remember. And the 2 weeks period time, what are the two in, I would say, the vaccines that you're going to give? One is H influenza B, another one is meningococcal C. Again, very, very important topic to remember. Another one is with respect to liver injuries. How do you manage it? It is 4P, push, plug, Pringles, pack. Not working with Pringles. What is Pringles? Clamping the hepatoduodenal ligament. Why are the foramen of Winslow? So that the portal triad is being compressed. If the bleeding continues to happen, you will do something called as Henle's maneuver. Supra-IVC, infra-IVC clamp. Look for bleeding. That is your Henle's maneuver. Next is about diaphragmatic injuries. We have discussed it. Then it is the hemorrhagic shock. Remember the categorization and the classification into class 1, class 2, class 3, class 4. All the parameters in shock are important. But remember the protocol for massive blood transfusion. In massive blood transfusion, the protocol is packed RBCs, FFP platelet ratio of 1:1:1. Remember 6 multi-donor platelets equal to 1 single donor platelet to prevent coagulopathy. That is important. We have already discussed the diaphragmatic injury. I've given all the important questions, points remembered for diaphragmatic injury. Then you have the cannulas, the color code, the flow rate, everything has been discussed. And the deadly dozen of the thorax. Remember, the only thing, this was the old edition of Bailey where the flail chest was given in immediate life-threatening. Now it is considered to be as potentially life-threatening. The thoraco-bronchial injuries are now moved down to immediate life-threatening injuries, right? Okay. Yeah, Sachin, you're correct. In trauma, the most important thing is to stabilize the cervical spine, and that is of most importance thing. Now, if you look at this is your trauma in a nutshell, right? So this is your mind map, right? When you look at a topic, you should be able to picturize the topic in this particular manner. I've tried to cover all the topics which are essentially important from the upcoming exam. Focus on these, revise, keep yourself calm. Just ignore the outside energy. Just ignore everybody else who's trying to tell you something. Advices at this point are not encouraged. Keep yourself calm. See, I'll tell you a very important thing. I know that you are capable of doing it. The only thing is you have to tell the guy you see in a mirror every single day that you are the best, right? Have that belief in yourself. Do not stop. Forget about what happens around you. Just make sure that every single minute of the day is going to be utilized. Again, an important thing, anybody who says no, you need 8 hours of sleep, 4 hours of entertainment, 6 hours of your own personal time and then read, guys, that's not going to happen. You are in the most competitive exam ever in the planet Earth, right? So you want to crack it, you have to give it. See, the only thing I would advise is if you want to rest, sleep or you read. Only 2 things, right? So you have to put in the last 2 weeks. You have to go ahead with 14 to 16 hours, if possible 18 hours a day. Do it again and again. Do not worry about what is going to happen. Forget about all that. You will feel so happy for the amount of effort that you have put. That will show the dedication, that will show the energy, that will show the mindset that you have. And remember, whatever you do, I don't know who is watching or not, but that guy is watching and he is very kind, right? You put in your effort, he won't let you down. With that, I would say thank you so much for your time. I wanted to keep the session as small as possible. I know your time is of absolute importance. Focus on these topics. Please come back again. We'll see once you get the scores, once you get the results, once you're down there, once you join your residency, reach out. And shout out to all you guys. All the very best for the exam. Guys, these topics, if you revise it, that is more than enough. That's it. ठीक है? Chalo. So all the best. Thank you very much for your time. Let's do it. Let's do it and not stop it until we do it. So signing off, Dr. Sandeep, your surgery guy.